Thanks very much, Maza. And what I'm going to do today is talk about how greed, when intertwined with an imperfect global health architecture, is what creates inequity on the whole, right? It's a combination of the two things. Now, this is a structure of the ACT Accelerator, and I sit as civil society representative on the Facilitation Council on the top. Facilitation Council is basically where the WHO member states sit, and the principals group on the right, which is the heads of the global health agencies, and that happens every bi-weekly on Thursdays, and where major developments are discussed. So, of course, in considering whether the global health architecture is fit for purpose, let's go through a number of things that have happened in COVAX. Now, this is a September 2021 forecast of how many supplies will be delivered or in the next in 2021. And in the September 2021 forecast, it said that further 1.1 billion doses are expected to become available to COVAX. So immediately we did some sort of simple math, and between September and December 2021, that's deploying at least 10 million doses a day. So, this was a little concerning for us as civil society on the ACT Accelerator, going, okay, what, is this feasible for deployment, right? And unfortunately, we didn't get a good answer to that. So there are some concerns about, the feasibility of getting this amount of doses and not necessarily having the logistics to deploy them further. But there are other things that are problematic with the COVAX. And I'm illustrating this story from the Bureau of Investigative Journalism. And I know there's been some critique of this article because the journalists are funded by Gates, and the role of Gates was not looked at as closely. But it also provided several really interesting insights about how countries were treated. And this goes back to Fatima's point on racism, right? Now, earlier in the COVAX, we had issues with the fact that CSOs couldn't unmute ourselves in Zoom calls with the COVAX facility. So there's a very weird, almost, a vision of what civil society, how civil society works. There were comments about how, we don't want civil society to be disruptive, when you're like, okay, that's interesting, because that's the exact purpose of what we're for. And arguably, if civil society had been involved much earlier in COVAX, it would be more equitable. But you see as well that the ACT Accelerator is predominantly global north, white led, right? Which is, for me, a real problem, because you lose that diversity and value of indigenous knowledge in the COVAX, and not just the COVAX, but throughout the diagnostics pillar, therapeutics pillar, and health systems, right? So it's really problematic. But this racism, as you can see from this article, transcends beyond civil society and here with LMICs, where you can see that officials found it difficult to get clear information from the COVAX. And the second arrow, the relationship with the Libya's COVAX coordinator got a little ugly, and the country's request for a meeting with Seth Berkley was met with silence. The third arrow underneath says that COVAX would sometimes just not pick up the phone. So, there's one thing about not being able to consult CSOs early enough and meaningfully involve them, right? Because we still get documents last minute. Sometimes we get documents and it's already version 7 in the file name. So, why are we intellectually not involved at the inception of these documents, which affect the entire world's supplies, right? So it's incredibly concerning, but also you can see that there is a lack of respect for countries and the value attached to equal intellectual partnership of LMICs. And of course, you've seen the article by Tian Johnson, who is in the audience, and Maaza here on vaccine hesitancy or systemic racism. These are sort of little things that are seeping into our conversations on the ACT Accelerator, of course, that, vaccine hesitancy really, it's being used as an excuse, and thankfully those conversations have died down, but it's definitely a real problem to be talking about this, and to have Pfizer CEO talk about it, right? Because the Pfizer CEO was like, vaccine hesitancy is going to be way, way higher in Africa. And the question is, does this come from data or does it come from prejudice? So it's quite important. I want to quickly go into country absorptive capacity because it's been discussed on the ACT Accelerator a lot. So country absorptive capacity is used to judge whether a country is worthy of X amount of vaccines or less, right? So I have real problems with the use of absorptive capacity because it's not being used to say, okay, let's invest in health systems, let's invest in community health workers to make sure we can deploy those vaccines and make sure, homeless people can come to the vaccine centers and things like that. Absorptive capacity is being used within the COVAX and within your diagnostics pillar as well, to say, okay, say Ethiopia or Somalia or South Africa, they don't have the absorptive capacity for, say, 1 million vaccines. So let's give them less, let's give them 500,000, and it's going to create lots of inequity. And of course, there's lots of other things going on that create inequity in treatments as well as diagnostics. And just on the final slide, the manufacturing task force, this slide shows basically what they're planning for the manufacturing task force. This is the last update I got, and I'm on the facilitation council and on the principals group. This was an update in June 2021, and it's October now. So I leave you with that to draw your conclusions, but I'm happy to talk more about it later. Thanks.